Welcome to the latest Greeley Healthcare Podcast regarding COVID-19. My name is Ann Smedly, a registered nurse, prior CNO, and a senior consultant with the Greeley Company. I'm heavily involved in Greeley's compliance practice, and I've been fielding questions from clients about staffing shortages. I've asked our advisor consultant for the compliance practice, Lisa Eddy, to answer some questions that we've had coming in lately regarding alternative staffing plans. Lisa is a registered nurse with a background in nursing leadership as well as compliance. We're going to get her insight on how organizations can manage staffing shortages during this COVID-19 crisis while still being mindful of regulatory requirements. Hello, Lisa. I'd really like to know your thoughts on what you're seeing in hospitals out there doing related to staffing shortages.
Hi, Ann. Thanks. Well, in the event of an incident that's causing a large influx of inpatients into a healthcare organization, contingency actions outlining alternatives to usual staffing plans are going to have to be developed, and I'm finding clients are talking about that. So the primary focus, what I tell them, the primary focus is always when you're implementing an alternative staffing action or plan or any alternatives to regulatory requirements or hospital policy is always patient safety. What I'm hearing from clients is really varied at present. I've heard everything from actual implementation of an alternative staffing plan to proactive discussions, planning on what we have. We don't actually have an influx of patients, but golly, a lot of our nursing staff and other staff, they're calling off because they've got their children home from school. So they can't come in. So I'm talking to clients, and what I think will be helpful is sharing some considerations in implementing or planning for alternatives to staffing issues. Here are some things I think you should consider, whether you have an immediate need or you're doing proactive planning. Likely, you're going to have to pull staff from certain areas that, because of the pandemic, COVID-19 that we're seeing, are less, that are seeing less patients. So you're going to be pulling staff from areas where we're seeing less patients and moving them to areas where more inpatients will be seen. So some of the considerations when you're looking at alternative staffings are, if possible, and you have the time to do it, we suggest you do an inventory of current staff to determine the skill set and competencies. This is not an in-depth inventory. It's just a quick evaluation of where throughout your whole organization, including your outpatient areas, your clinics, and so forth, where you have licensed staff performing specific duties so that you'll know where you can pull from, like I said, and then move to. And don't forget, you likely have some administrative clinical staff who can be moved to patient care activities such as clinical educators, perhaps managers or clinical staff performing QAPI or risk management duties. They perhaps can be pulled. And then you might want to be able to discuss, can these people, when you do your full inventory, have they been so long out of patient care that that's just not really going to be possible, or could they really step in and provide active inpatient care? So we want you to look at the existing staff that you have and where you could be placing them. And when you do that, you're likely going to be putting staff in some areas where they don't have the exact same clinical expertise, but there's a number of variations on this, and this is what I've been hearing and seeing. But so people are pulling staff from, say, that have like clinical expertise from critical care areas such as CVICU, and they're moving them over to MICU, or they're asking nursing staff that are usually staffing the PACU and have experience with that, moving over to critical care and so forth, sort of back and forth, or advanced practice nurses to critical care areas as appropriate. So if we've reduced our elective surgeries and we don't have our CRNAs that are very busy, the CRNAs can go up to the critical care unit. So that's something to think about. And then also organizations are telling me they're assigning staff with the same level of licensure, but without the same clinical expertise. So that would include individuals that are, say, RNs or LVNs or LPNs that are working in the clinic environment and moving them over to inpatient roles, such as you could take somebody that was working in a clinic and you might want to put them on a medical surgical unit. The skill set can be somewhat similar, but there will need to be some oversight to make sure that we're still able to perform the activities that are needed on that unit. Then we also have assignment of staff with a different clinical scope or licensure or without certification to areas where they can provide care, but they have to be under close supervision. So this would be if you were to take an LVN or LPN or a CNA and let's say move them to the emergency department, you're not going to ask them to be doing RN emergency work, but you are going to ask them to do things that are within their scope, such as such as taking vital signs, getting the patient's verbalization of their condition and reporting that. They're not going to be doing an assessment, but they can certainly provide information from the clinics to the RN staff member. And then other disciplines. So it's not uncommon. Many states allow, and many states have this as common practice, where a nurse, the registered nurse, will be providing, or even an LPN, providing respiratory therapy treatments, medications, because they have the license to give those medications. We might, if it's not usual practice for your hospital, you might want to be able to train those nurses on how to give those respiratory therapy treatments, especially in this COVID environment, where so many patients will be having respiratory issues. And then we do want to think about any time that you're moving staff from one location to another, you will need to ensure that orientation of that alternative staff is conducted. So it's very important to understand they need to have a very quick sort of real-time onboarding, if you will, orientation to the unit that they're going to be covering, and to any if you let's take a med surg nurse and you're very short in the ICU. You take that med surg nurse and you move her up to ICU, or him up to ICU. You will need to make sure that you focus on patient safety, and you make sure you understand what types of procedures or treatments or assessments are expected within a given population, and that nurse that you've moved to that higher level of care gets a very quick update on what they need to be understanding, and sort of a competency check on that. And then you do need to look at staff safety. So if you take somebody from the clinic environment, let's just say, move them over to the inpatient environment, and you have different policies or codes or things that you are specific to the inpatient that you would call overhead, the staff need to understand and know that, or any policies specific to the inpatient related to patient care that they're going to be now using or expected to follow. They have to understand that. And again, I want to talk about when we move someone from one location to another, when you move them from one scope to another, there has to be rapid orientation, and the focus there would be on the essentials for safe patient care. So when you do that, think a focused or mini sort of agency onboarding. Like when you have agency staff that comes in, you have an onboarding tool that you use to get them familiar. You might want to make a really rapid fire, quick mini orientation to that nature. And then we would also look at cohorting of patients to allow for care in a proximate environment. So we're keeping staff sort of centrally located. Extension of hours of work, hiring of temporary staff if that's available, and then care by volunteer staff. You know, a lot of organizations we deal with are large teaching facilities, and we're seeing some of those facilities bringing in some of the faculty staff, emeritus staff members, or actually professors or faculty staff coming in to help at the bedside. So those are just some of the considerations that we would want to be thinking about.
So Lisa, again, can you explain what happens when there is a requirement for a staff member on a given unit to hold a hospital required certification, and another staff member without that certification is scheduled on that unit?
I know what you're talking about. So you've got someone that is coming in from a clinic, let's say, where they don't require that you have, the hospital's required that you have BLS. CMS does not require that or mandate that, but many hospitals require that. Or for instance, in a psychiatric hospital, let's say that you have somebody doing IOP and you bring them into actually, the inpatient unit, and they don't have CPI or MANT training or any of those trainings where your SAMA training, where you do a takedown of a very escalated patient, a safe takedown as a form of sort of restraining them to where you can get them to a calmer environment. What would you do in that instance? Well, you would need to have somebody available to that unit that has that same certification so that they can provide that level of safety for the patient. So you would want to make sure that you've staffed individuals that can respond quickly and perform that the activities that are within that certification. Does that make sense?
Yeah, yes, it does. You also mentioned using staff from outpatient or clinic environments in the inpatient unit. Since many clients have expressed time sensitivity with increased patient influx, what type of orientation is expected when staff who do not generally staff a specific unit are asked to do so?
Well, that is one of the things that organizations are struggling with, and that's why we suggest that really rapid mini orientation, and it really needs to be focused on the unit that they're giving and the care that you're asking them to provide, and the unit where care is given, and what the care you're asking them to provide. So you don't want to be training them on soup to nuts on hospital policy and like they would sit through a 3-day orientation. You need to be able to focus down and give them the information that allows them, sort of like real-time teaching, that allows them to provide the care that they're expected to give.
Yes, that makes sense. Now, do you think it's okay for a seasoned, experienced nurse to oversee multiple nurses without the same level of expertise, even if those nurses are being asked to perform activities beyond their existing skill level?
Well, and you as a prior CNO in a number of institutions, and I mean, with my background, we've seen a lot of different models of nursing in our time. And I think what you're referring to right now, it's happening all over the country. And I bet a lot of clients talk to me about it. There's a lot of information out there on the web and listservs and so forth, where hospitals, particularly with large influx of inpatients, perhaps in a critical care unit, they're pulling med-surg nurses that just don't have that critical care expertise and asking them to perform critical care activities. Even in critical care assessment, a med-surg nurse really hasn't done the same type of assessments that a critical care nurse is experienced in doing. But I think what you're talking about, back in the day when I went to nursing school, when the earth was cooling, we actually had several different types of models: functional nursing, team nursing, and then we moved to primary care nursing. But functional nursing, as you know, is where one nurse does one task. So one nurse does all the medications, one nurse, then a different nurse does all the treatments, a different nurse does all the assessments, that kind of thing. I don't think that's what we're seeing right now. I think what we're seeing is a move back toward team nursing, where one primary nurse or one oversight nurse is overseeing the clinical activities of 2 or 3, sometimes more, hopefully not too many in the ICU, nurses that don't have the same level of expertise, but they are performing critical activities. Do I like that? Not necessarily. Do I think it is something that can be done in this particular environment? Yes, if the oversight is adequate. So in other words, you don't have a med-surg nurse taking the highest acuity patient in the ICU. You have a med-surg nurse taking the lowest acuity patient in the ICU, with that very seasoned nurse overseeing her, or perhaps another or even a third nurse. But you would assign the lowest acuity to the individuals that don't have the highest level of expertise. We do have some regulatory requirements that we need to consider when we're doing alternative staffing. CMS does not dictate how you staff an organization. That what they do say is that you have to have staffing schedules that meet the sort of, I'm paraphrasing, but the acuity of the patient. So you have to have nursing, under nursing services, you have to be able to staff 24/7 inpatient units, and you have to be able to meet the needs of the patient and the acuity of the patient and so forth. They don't speak about a specific staffing plan or schedule, but some state agencies do. And so you'll want to make sure that if you are using alternative staffing, that you check with your state agency and make sure from a regulatory standpoint they understand and there's sort of an approval. There are some states, California, I'll give you an example, is one of them, that issued an all facilities letter that pretty much waived any type of requirements under, I mean, pretty broad waiver of following requirements, the state requirements to the T. But you would want to make sure that you got your hands on what the state required. And if there's no waiver or there's no allowance for you to change your staffing, then you'll need to check with the state. But understand, the state governs the scope of practice of the individuals. The Board of Medicine for a specific state, the BRN for your, Board of Registered Nursing, Board of Licensed Vocational Nurses, and so forth. So it's not CMS that governs it, but it's the state. So you will want to make sure, if you have somebody that's practicing a little bit out of their scope because they absolutely have to, we have no other choice, then you'll want to make sure we check with the state, look at those guidelines, and see where we stand with that.
Lisa, another question. What kind of documentation for temporary assignments will be needed, especially in meeting these regulatory requirements?
Well, you're likely not going to have enough time to do the kind of vetting, and we're not talking about somebody that's actually, when we talk about vetting and background checks and all that thing, that's already part of your organization. This would be in relationship to people that come in as volunteers. As I mentioned, you can have volunteer staff, or maybe a faculty staff that comes in, or whatever it happens to be, a retired nurse, and CMS is allowing us to bring in many individuals with healthcare experience to function in a multiplicity of roles due to the crisis. So what you want to make sure that you do is get a start date, that you document the start date for this individual, who they are, when they started, what their level of experience licensure is, and then when they stop providing that care, meaning when you no longer have them on the schedule for that particular unit, issue, whatever. So you'll want to make sure that you capture that, and then you'll have to decide with your own organization what your basic requirements are. But keep in mind, you're not going to have time necessarily to do primary source, checking of licenses. You're not going to have time to do a background check. So your organization is really going to need to determine what they can feasibly do. And then you have to consider the backside of this. When everything is over and the disaster has been called, and it's the president and the secretary of Health and Human Services say the disaster is no longer invoked, then you'll need to go back and make sure that you can pick up any of the things that you really didn't get to make sure that you got your I's dotted and your T's crossed. So those are issues that you'll want to cover. Additionally, I would be very careful that orientation that we talked about, that sort of rapid orientation to whatever role or unit you're asking somebody that doesn't have that level of expertise. You'll want to keep that on file too as a document to sort of prove that you in fact did the best that you could do under the circumstances to get that person caught up. So for example, we have had some clients that have med-surg nurses managing a ventilator because in an ICU in a CCU environment, because there's not enough ICU staff to go around. And so what happens then? Well, first of all, keep in mind that you're going to have respiratory therapy managing the settings on the vent and managing the trach changes and things of that nature, although a registered nurse can certainly do that. But if you have a med-surg nurse maintaining a ventilator patient, likely the oversight nurse that's skilled and seasoned is going to be, if there's a vent change or if we're going to do weaning or whatever, that the nurse would be involved in, that oversight nurse should really be with that med-surg nurse and make sure that they understand what they're doing, understand the assessment components. And then once that they feel comfortable, they being the oversight individual, then that med-surg nurse likely doesn't have to have direct observation continuously. But when you're having somebody that's never dealt with a vent before, they do have to have education and training on it, quick, rapid, concise, but they can manage that. It's just a matter of making sure that as they do that, they're fully understanding and they're competent. So, and those kinds of things really should be documented. We're not talking about a lot of documentation. We're talking about something that's quick, simple, and easy, but is succinct and lets the viewer know that the activity has been assessed and is competent. The person's competent to do that. Does that make sense, Ann?
Yes, it sure does, Lisa. Thank you. Well, thank you, Lisa, so much for your time today. This was very helpful. As Lisa explained, there will be a considerations document posted on the Greeley website where listeners can hear this podcast and review the document that lists considerations for alternative staffing plans in the event of a disaster with resultant large influx of patients. We appreciate your time today and encourage you to review other COVID-19 podcasts and documents at Greeley.com. That's Greeley.com. Thank you all.